what if, as we mentioned, the only graft available is an ABA incompatible graft? Testing for compatibility between donor and recipient for ABO and HLA has already been mentioned. Now, can we perform a transplant between an ABO incompatible, antibody incompatible donor and recipient? If this is the only option to save the recipient's life, we can try, but we diminish the antibodies or donor-specific antibodies in the to a safe level prior to transplantation. This can be done by filtration or plasma exchange through special columns that absorb antibodies. It can also be done by preventing further donor-specific antibody synthesis in the recipient by pan-lymphocyte depletion. Actually, we need to deplete the B cells, which are the antibody-producing cells. So if we have a method to deplete B cells only and leaving T cells intact, but the T cells may still recognize HLA presented by antigen-presenting cells and stimulate B cells to produce antibodies against them. Pan-lymphocyte depletion can be achieved by anti-thymocyte globulin or the anti-CD52 monoclonal antibodies called alemtuzumab. The CD52 is a glycoprotein present on T cells, B cells, antigen-presenting cells, natural killer cells. So when this receptor is blocked, its effects are inhibited, and the cells, these types of cells, then do not proliferate. A note about the nomenclature of monoclonal antibodies. Monoclonal antibodies are antibodies that react only against one type of antigen or cells bearing that antigen. The end of the name is MAB. MAB signifies simply monoclonal antibody. The two letters preceding the MAB in the name of a monoclonal antibody may be ZU, ZU, or XI, XI. ZU meaning that this antibody is of purely human origin, such as alemtuzumab. The XI, such as basiliximab, XI and then MAB, means that this antibody is part rodent, meaning a rat, mouse origin, and part human in origin, and this is called a chimeric antibody. The third technique in which we can allow us to allow us to proceed with an antibody incompatible transplant is to inhibit complement activation. The antibody reaction, when bound to their antigen, may include a complement activation and then disruption of cells through membrane attack complex and cell-mediated, antibody-mediated phagocytosis and cytotoxicity. We have an immunosuppressive drug which is against the complement component C5a. It is eculizumab, and again, zumab means that it is purely human in origin. Now we come to immunosuppressive drugs. Immunosuppressive drugs reduce the overall competence, immunological competence of the recipient, and are used with success to permit allograft acceptance. However, they have general complications because of reducing the immune competence in the recipient. They increase the susceptibility to infections, and infections such as by organisms that would not normally be strong enough to cause infection in a normal immune in a person with a normal immune system, and these are called opportunistic infections, such as pneumocystis jirovecii or fungal infections that would not normally infect a person with a healthy immune system. In addition, they can also increase the rate of post-transplant malignancies, mainly skin cancer, lymphoma, Kaposi sarcoma. The incidence is 5 times higher in post-transplant patients than in the general population. And other cancers are also increased, though at a lesser, in a lesser proportion, colon cancer, kidney cancer, etc. So, when asked about the toxicity of immunosuppressive drugs, you must mention A, general toxicity of all immunosuppressive drugs resulting from the immunosuppressive function, and then specific toxicity related to the individual or to the immunosuppressive drug used. This is a diversion. This nodule appeared on the upper lip of a person that has been transplanted, had received a kidney transplant 2 years previously, and of course has been on immunosuppressive therapy. The immunosuppressive therapy lasts for as long as the graft is still functioning. This is called maintenance immunosuppressive therapy. Actually, this tumor, this little nodule, turned out to be a Kaposi sarcoma. So, immunosuppressive drugs are used in 3 ways. A, induction, to induce immunosuppression, and B, maintenance. The induction is at and for a short time after transplantation. Maintenance is throughout the life of the graft, and then rescue therapy, or when acute rejection episode is detected, we increase the dose of immunosuppression, give steroids, or some, according to different centers, use different protocols to treat acute rejection. This is an overall illustration of how to use immunosuppressive therapy. First, there is induction, which can be done by an interleukin-2 receptor antagonist, such as basiliximab, anti-CD25, or it can be done by depleting lymphocytes, say by acymocytic globulin or anti-lymphocyte globulin. For induction, we use an intravenous sulfaprednisolone is usually used, because induction we need an intense immunosuppression regimen, because this is the time when the risk of acute rejection is highest. So induction immunosuppression is very intense and short, given for a short period, peri-transplant. We cannot give it for a long period because it will harm the host. After the induction period, we start giving oral immune suppressive drugs which continue throughout the life of the graft, with monitoring of the recipient at increasing time intervals, weekly for 3 months, and then 2 weekly for a month, and then monthly, and then every 3 months, every 6 months, etc. The oral maintenance treatment is given orally, usually. The induction treatment is given by injection peri-transplant. When monitoring shows that something has gone wrong by symptoms, graft tenderness or pain, fever, and we said that these symptoms are non-specific, we do lab tests and treat, and if there is no response, we do a biopsy of the graft and treat accordingly. So, the first and most commonly used immunosuppressive drugs for induction and also for maintenance therapy, although they have complications if we are used long term in maintenance. So, the mode of action, they act in 2 ways: as immunosuppressive, as anti-inflammatory. The immunosuppressive action, by binding to the intracellular receptors, they inhibit transcription of interleukin-2 and other cytokines. The anti-inflammatory action, they inhibit immune cell transmigration across vascular endothelium and impair macrophage and neutrophil action. Side effects are many with long-term use: hypertension, hyperglycemia, hyperlipidemia, cataract formation, osteoporosis, psychosis, pancreatitis, GIT, ulceration, perforation, bleeding, etc. Calcineurin inhibitors. These include cyclosporin, which the trade name is Neoral or Sandimmune, and tacrolimus, also known as FK506 or Prograf. These are currently the mainstream maintenance medication in many centers. Remember that different centers use different protocols. Tacrolimus-based regimens are superior to cyclosporin-based regimens, so centers which use calcineurin inhibitors prefer to use tacrolimus rather than cyclosporin. The mechanism of action. They inhibit interleukin-2 production. And we said that interleukin-2 stimulates T cells to secrete more interleukin-2, leading to their differentiation, and activates CD8 toxic lymphocytes and other immune cells such as macrophages in a non-specific way, which enhance destruction of the graft. So interleukin-2 production, if it is inhibited, is a very effective means to prevent immune system activation. So the cyclosporin or the calcineurin inhibitor inhibit interleukin-2 production by forming a complex with an intracellular protein that binds to and inhibits calcineurin. So we have cyclosporin or tacrolimus binding to an intracellular protein, and this intracellular protein inhibits calcineurin. Calcineurin is a phosphatase. It is an enzyme that splits phosphate groups from its substrate. Therefore, it dephosphorylates NFAT. NFAT is nuclear factor of activated T cells. It's a protein in the cytoplasm which is phosphorylated. Being phosphorylated, it cannot enter the nucleus. When it is dephosphorylated by calcineurin, a phosphatase, which removes the phosphate group on NFAT, NFAT will enter the nucleus. It's then going to bind to the promoter region of interleukin-2 gene, leading to its transcription with increased production of interleukin-2, which is then going to stimulate other immune cells and its own CD4 T cell that has produced. Side effect. Nephrotoxicity is the most serious long-term side effect of calcineurin inhibitors. So when you asked about the mechanism of action and the complications of calcineurin, you do not forget nephrotoxicity. Other side effects include hypertension, hyperkalemia, hypomagnesemia, tremors that may progress to seizures in severe reactions or susceptible individuals. Gingival hyperplasia and hirsutism occur only with cyclosporin. Tacrolimus also causes GI irritation, nausea, diarrhea, and diabetes. In addition to these things are the effects mentioned before, nephrotoxicity being the most serious. These drugs are metabolized by the cytochrome P450 enzyme system in the liver. And therefore, attention is necessary to other drugs given in addition to calcineurin inhibitors, because some drugs, say like phenobarbital, phenoxytoin, will induce or increase activity of P450, therefore reduce the dose of calcineurin inhibitors. Some drugs do the reverse effect. The second group or third group of immunosuppressors are called cell cycle inhibitors, also mTOR inhibitors. Excuse me. mTOR is short for mammalian target of rapamycin. Sirolimus, also called rapamycin or rapamune, and everolimus belong to this category. They block signal transduction following interleukin-2 receptor ligation or binding. When interleukin-2 binds to its receptor, CD25, it will result in signals being sent downstream into the cell to eventually activate cell proliferation and produce the effects that interleukin 2 is responsible for. So when interleukin 2 binds to this receptor, you can prevent the effect of interleukin 2 either by blocking the receptor so that interleukin 2 does not bind to it, or blocking the signal transduction which occurs in the cell for eventually or ultimately producing the effects of interleukin 2. How they do that? They bind to FK binding protein. Remember, not calcineurin. They bind to FK binding protein to form a complex. Again, it's like calcineurin, but calcineurin inhibitors bind to a protein other than FK binding protein to form a complex that binds to and inhibits, unlike calcineurin inhibitor, the complex of the rapamycin or everolimus with intracellular protein binds to not calcineurin but to a kinase called mammalian target of rapamycin. A kinase, as we said, is an enzyme that adds the phosphate group to its substrate, giving it an energy-rich bond that, when split, can provide enough high energy to start a chemical reaction. mTOR is required to activate cyclin-dependent kinases, which drive cell cycle progression. During mitosis, the cell enters into different phases from G1 to S phase. The S phase is the synthesis of DNA to produce twice the amount so that there will be enough DNA to share between the two daughter cells. They thus prevent T cell proliferation and activation in response to interleukin 2. They may allow early withdrawal of steroids and decrease calcineurin inhibitor doses. The former have long-term effects which we have mentioned. The latter mainly cause nephrotoxicity, and if this happens, we need to change them. If both of these are part of the maintenance program, we can substitute sirolimus or rapamycin everolimus for these instead of the calcineurin inhibitor or the steroid to treat the complications induced by these two agents. Sorry for the interruption. They also inhibit vascular endothelial growth factor pathway. This prevents angiogenesis, a property which is used in the treatment of certain cancers such as Kaposi sarcoma. Side effects: they inhibit cell cycle, so rapidly proliferating cells will suffer. Thrombocytopenia, neutropenia, in addition, they have metabolic effects, increased cholesterol LDL, low density lipoprotein, cholesterol. They cause extremity edema and poor wound healing. They do not cause hypertension, neurotoxicity, or gingival hyperplasia. So if these complications occur as a result of calcineurin inhibitors, you can stop the calcineurin and use mTOR inhibitor. Antimetabolites. Mycophenolate mofetil, trade name Cellcept or Myfortic, and azathioprine, trade name Imuran, inhibit DNA synthesis, which must occur prior to cell division. The cell must form double the amount of DNA so that there is enough DNA to share between the two daughter cells. So by inhibiting DNA synthesis, they inhibit cell division. Both are prodrugs. They are not active drugs. They are converted in the liver to their active form, mycophenolic acid and 6-thioguanine, respectively. Azathioprine is converted first to 6-mercaptopurine and then 6-thioguanine. Mycophenolic acid inhibits the synthesis of it's important. I mean, these are details that is important in the case of mycophenolic acid. It inhibits the synthesis of guanine which is necessary, one of the 4 bases in the DNA. It does this by inhibiting what is known as the guanosine nucleotide synthesis de novo pathway, but not by the salvage pathway. So there are 2 pathways to eventually produce guanine: the de novo pathway and the salvage pathway. Mycophenolic acid inhibits the de novo pathway, but not the salvage pathway. And this allows selective inhibition of lymphocytes, because lymphocytes do not have the salvage pathway, but they have the de novo pathway, which is inhibited by mycophenolic acid. Side effects, most commonly GIT, nausea, diarrhea, dyspepsia, and bloating, and bone marrow effects, leukopenia, anemia, thrombocytopenia, that are contraindicated in pregnancy. Azathioprine is a substitute for guanine molecule. The guanine, the 6-thioguanine, as the name implies, is sufficiently close in structure to guanine, one of the 4 bases in DNA. So 6-thioguanine can be incorporated into DNA, but it does not allow its replication. It is used primarily in patients intolerant of mycophenolate mofetil. Side effects, bone marrow suppression as usual, in addition hepatitis, cholestasis, alopecia, pancreatitis is contraindicated in pregnancy, and in patients on angiotensin converting enzyme inhibitor, as the combination can result in severe anemia and pancytopenia. This is to remind you of the structure of an immunoglobulin, a Y-shaped molecule with a stem which is constant for each class, and the Y-shaped open arms of the Y bear at their end the receptor for the corresponding antigenic epitope. How are antibodies used to prevent immune responses? There are several options. There is the T lymphocyte antibodies. Antibodies directed against cell surface protein molecules on T cells may be polyclonal, they act against many molecules, or monoclonal against one specific molecule. Antibody-bound T cells are then removed from the circulation by the lymphoreticular system, say in the liver, in the spleen, by being opsonized, and then phagocytosed by antibody-dependent complement-mediated cytotoxicity. Polyclonal antibodies, which are active against many types of molecules, include thymoglobulin, anti-lymphocytic globulin. These are polyclonal preparations obtained from the serum of rabbits, in the case of anti-thymocytic globulin, or horses. The preparation from horses is known as ATGAM. We immunize these horses by inoculating them with lymphocytes or thymocytes from humans. Then, after a suitable interval period, the rabbit or the horse is going to produce antibodies. It's like the antitetanic serum from horses. These antibodies are the plasma from these animals is then removed, withdrawn, and the Ig immunoglobulin containing fraction is purified. However, it does not only contain antibodies to lymphocytes, but also to red blood cells and platelets, being of xenogenic origin. Xenogenic means from a different species altogether. They are recognized as foreign by the immune system, and neutralizing antibodies are formed against them, which prevents recurrent use. Limitations: lack of specificity. They target many antibody molecules. B, the cytokine release syndrome, which occurs in up to 80%. This is a massive cytokine release from cell lysis, which can cause severe flu-like illness, fever, chills, dyspnea, bronchospasm, acute pulmonary edema, and CNS complications. Of course, this cytokine release is following antigen-antibody binding. immunothermocytic globulin is used as induction therapy in some centers, especially in the United States, and also is used for the short term to treat steroid-resistant acute rejection. Now, instead of the polyclonal antibodies, we have monoclonal antibodies. These are directed or target one specific antigen type. They have a single specificity, as we said, and they are derived from a single plasma cell clone. You remember that the B cells which produce antibodies, when stimulated, turn into plasma cells which produce antibodies, and some of these plasma cells are short-lived, while some are long-lived and stay in the marrow as memory cells, which are reactivated when the body encounters the same antigen a second time. The monoclonal antibodies can be divided into three types: xenogenic, chimeric, and humanized. Xenogenic means that the whole immunoglobulin molecule is derived from another species, usually murine, mouse plasma cells. An example is OKT3 muromonab, which was actually the first monoclonal antibody to be used. It is an anti-CD3 monoclonal antibody. The CD3 is a molecule that is necessary for activation of the T cell receptor signaling. We said that T cell receptor, when it binds its cognate peptide presented to it on HLA molecule class 2, and then becomes co-stimulated, it will start sending a signal into the cell to eventually produce interleukin 2. This reaction, signaling by T cell receptor, is necessary. CD3 is necessary for this reaction. So the OKT3 or muromonab is by blocking anti-CD3 receptor prevents T cell receptor signaling. It is the entire IgG molecule is derived from the mouse. A chimeric means that a part is human and a part is animal. The chimera is a mythical animal with the body of a lion, the tail of a cell, wings, etc. So chimeric means made of parts from different animals. An example is basiliximab. And remember, the mab at the end stands for monoclonal antibody, and the xi preceding the mab, meaning that the antibody is chimeric, partly animal, partly human. The trade name is Simulect. It blocks the interleukin 2 receptor, CD25, the antigen binding part of the IgG molecule, that is the variable region, is murine in origin. The Fc portion, that is the stem, is of human origin. It is often used as an induction agent in renal transplantation. Neutralizing antibody may form against a variable region with repeated use. Being of foreign origin, it will induce an immune response. The first response will be delayed and may be mild. If we encounter, the immune system encounters the same antigen a second time, a second response, second set rejection or second antibody response occurs, producing a faster and stronger response. The third type of monoclonal antibody is the fully humanized antibody, almost. An example is alemtuzumab, trade name Campas IH. This is almost completely humanized. Only a very small region is of rat origin. It binds CD52, a glycoprotein present on the surface of lymphocytes, dendritic cells, and natural killer cells, and by preventing its function, it leads to rapid and sustained depletion of both T and B cells. It is used at induction and to allow a steroid-free maintenance regimen. Another group of anti-T lymphocyte antibodies is known as fusion proteins. Now, fusion proteins are fully humanized monoclonal antibodies. All the components of the IgG molecules are of human origin. The Fc part of IgG is fused with a soluble receptor of a target molecule. And attaching this receptor to IgG is to prolong the half-life of the soluble receptor. Belatacept is a fusion protein with a specificity for the B7 molecules on T cells. It inhibits the CD28 B7 interaction, that's to say, the co-stimulatory signal necessary for stimulation of T cell. It is used as a calcineurin inhibitor replacement in kidney transplantation. Side effects: increased risk of post-transplant lymphoproliferative disorders, especially in recipients who are Epstein-Barr virus seronegative. Why? Because these recipients are highly likely to develop infection with Epstein-Barr virus, which causes infectious mononucleosis, and Epstein-Barr virus lies dormant in B cells and eventually leads to B cell proliferation, malignant proliferation. As a result, post-transplant lymphoproliferative disorders are especially common in those who are seronegative to or for Epstein-Barr virus. Rituximab, monoclonal antibody, Xi meaning chimeric, is a chimeric monoclonal antibody against CD20, which is a marker on B cells. It is used for treatment of several types of lymphoma, B-cell lymphoma, of course. It is treatment of antibody-mediated rejection, usually plus plasmapheresis, steroids, and intravenous immunoglobulin, which by blocking the antibody binding to antibody receptors on B cells will prevent the action of antibodies, allograft, donor-sensitive antibodies in the recipient. It is also used in desensitization protocols, which, to remind you, if a graft is incompatible to a donor, but is the only possible option available to save that, incompatible to a recipient, sorry, but is the only available option to save the recipient's life, it may be used after desensitization of the recipient to diminish the donor-specific antibodies present in that recipient to a safe level. Another drug is bortezomib, a proteasome inhibitor. Proteasome, don't be confused by or shocked by the name. It's simply a compound, a complex made of several proteins within a vesicle inside the cytoplasm, an endosome. And this proteasome, this complex of several proteins is necessary for production of, for division of the cell and for production of important molecules necessary that the cell normally produce. It is necessary or useful for treatment of myeloma. It induces apoptosis of mature plasma cells, decreasing antibody production in sensitized patients. Plasma cells lack the CD20 of B cells, hence are not responsive to rituximab. Eculizumab is a humanized monoclonal antibody, ZU-MAB, ZU meaning humanized, for the fifth component of complement. It is useful to treat antibody-mediated rejection, which is often associated with complement activation, and to desensitize patients pre-transplant. Because of high risk of infection, especially due to encapsulated bacteria, vaccination against Neisseria meningitidis should be given at least 2 weeks before giving eculizumab, the same as in splenectomy with pneumococcus and Haemophilus influenzae type B. All these are encapsulated organisms that need opsonization for to be phagocytosed, and the main opsonin produced against these organisms is produced by the spleen. So splenectomized patients receive vaccines against these organisms. This is a summary of antibodies, mechanism of action, and complication. Usually in the exam, 3 or 4 of these antibodies are mentioned, including steroids, obviously, possibly calcineurin inhibitors, and 1 or 2 more. And you're asked to mention the mechanism of action and complication. Post-transplant infection, predisposing factors are immunosuppression. Early infections within 1 month are like ordinary post-operative infection. Late infections are related to maintenance immunosuppression of T cells with predisposes to viral, fungal, and parasitic infection. It is important to use prophylaxis such as oral nystatin for 1 month for Candida, 6 months oral Valgan cyclovir and trimethoprim sulfamethoxazole for cytomegalovirus and pneumocystis pneumonia respectively. Organ procurement may be from live or dead donors. I'm sorry, I'm being pressed for time, so it's easy. You can read it or listen to this on your own, no problems. You can contact me if necessary on my email if there is any item or any information that is a bit vague to you. My email is mhrateb@gmail.com. MH, small letter, RATEB, all small letter, at gmail.com. So all this you can do on your own, and again, contact me on my email if necessary for any explanation. I'm sorry, I'm being pressed for time, so I have to go now. I just to summarize, the immune system evolves to defend the organism against non-self or harmful substances. It recognizes non-self structures by lack of expression of self markers or expression of markers of foreignness. CD4 T cells, positive T cells, orchestrate the adaptive immune response and recruit other immune cells such as CD8, cytotoxic T cells, macrophage, and natural killer cells. Immunosuppression is necessary to prevent allograft rejection. Transplanted patients are followed up at increasing intervals to detect and treat rejection episodes or post-transplant rejection. Thank you, and don't forget, my email is mhrateb, mhrateb, all small letters, at gmail.com for anybody who needs any clarification of something in that lecture. Thank you again.